Good evening and welcome to this evening's webinar. I'm Dr. Ed Owens and I'm going to speak about sleep medicine and specifically its relation to dentistry. Where better place to start? Sleep that knits up the raveled sleeve of care, the death of each day's life, sore labour's bath, balm of hurt minds, great nature's second course, chief nourisher of life's feast. This is from William Shakespeare, Macbeth. Very eloquently sums up the restorative qualities of sleep. Now, as we move into the 21st century, sleep science has unlocked many of the mysteries surrounding sleep, and there's a huge interest in the area in the general community, medical community, and worldwide throughout people of all ages. So what I decided to do was set out some learning objectives this evening, which I have forwarded, and thank you, Elaine, for the invitation to speak. What I wanted to do was really to focus on what has dentistry to do with sleep medicine, answer some of these questions. What is what we would consider sleep disordered breathing? How is it diagnosed and why is it medically significant? How can we collaborate in the management of these presentations? What is oral appliance therapy? What does that mean? How does it work? What's its scope and limitations? Are there side effects to this therapy? And what are the considerations around the patients we might select or not select for this type of therapy? What are some of the newer technologies impacting this area of practice? Well, that's what I'd like to finish up with. So sleep in general, in society today, there's a heightened public awareness of sleep conditions. The RSA, driver licensing, the courts, the media health, they're replete with information in this respect, and the significance of sleep as it affects various motoring and other considerations in that respect. There's a perceived need out there in terms of the increase in number of wearables, where maybe the worried well, but certainly the informed well, I think, really as well. And bed partner reports. These are situations whereby disruption is a feature of the nightly nightly sleep for the partner and for the individual who may be experiencing sleep disordered breathing. So knowledge of therapies and alternatives is becoming quite widespread as well. There's plenty of information on the search engines, and there's new points of contact emerging all the time in this respect. So this brings many patients in our doors to referral to dental practice providers, and this causes some ethical and medical legal considerations. And are there guidelines out there to support these types of practices, and how can we position ourselves in this area? Well, let's begin by looking at who's at risk of sleep breathing and how is it screened for, or how is it reported. Well, the prevalence of, when we're talking about sleep breathing disorders, we're going to kind of collate sleep apnea, snoring, and maybe sleep bruxism as well. So sleep apnea is a condition that has a number of variants in it. The estimated prevalence is 5 to 10% of the population. Again, this could be low, this could be slightly higher. Snoring, which is more common and is associated with sleep disordered breathing, in the 40 to 50% range. Huge gender differences in sleep disordered breathing presentations. Males outnumber females 4 to 1. But there are kind of temporal considerations here in terms of pregnancy and early menopause, which may increase the number of females presenting with these problems. Sleep bruxism is estimated at a prevalence rate of 8% to the general population through a number of studies. So how are these disorders screened for? Is there screening tools out there? Well, sleep disordered breathing is associated with daytime sleepiness, and sleepiness is associated with drowsy driving and other considerations in this respect, falling asleep at meetings and things like that. So there's an Epworth sleepiness scale, which is widely available on the internet, which will give an algorithm for predicting your risk of excessive daytime sleepiness, so sleepiness that's not normal. And other questionnaires like the Stop Bank questionnaire, which is a collation of various anatomical and physiological data, would give a predictive algorithm to the presence of a suspected sleep apnea. We can look at neck circumference, and we'll see the significance of that in the patient population that we see every day of the week. That might bring us to a consideration that these may be individuals who have some degree of propensity or tendency for sleep disorder breathing events. And of course, there's a plethora of technology out there now, wearables, more sophisticated sensor devices that are giving us data sets created all over the place, really, that are highly informative in certain areas in terms of sporting community and the wider general population. So how does the reporting mechanism occur? Well, there's the medical checkups. So the physicians are more aware of this condition now. They're more aware of the need to refer. They refer to ENT surgeons, to respiratory physicians and sleep physicians, depending on the severity and presence of symptoms. A lot of the activity in terms of bringing people into a clinical environment to have this area investigated are from the bed partner. They're prodded and poked and they're elbowed into submission at nighttime to reduce the noise they're making. So the observer reporting is a significant aspect in the genesis of a pathway to dealing with these problems. So how are these sleep breathing disorders diagnosed? Well, the medical standard for diagnosing sleep disordered breathing is polysomnography, commonly known as PSG. PSG studies occur in hospital environments or in sleep laboratories. They measure a significant number of physiological parameters, collate that data. It's examined by respiratory physician or physiologists and physicians, sleep physicians, and reported on to categorize the severity or otherwise of the presentation. Home sleep testing is a slightly less complex variation of the same theme. And these devices, these studies, they track various periods of sleep, generally over an hour and a half, 90 minutes cycles. So it may be 4 or 5 90-minute cycles, and they collate the data. Obviously, sleep is not a flat platform. There are various physiological changes that occur during sleep between non-REM sleep and REM sleep or dream sleep. And these are recorded in detail. So once a scoring mechanism is established for the parameters that are under investigation, certain indices can be created from that, which will identify the complexity or otherwise, or the severity of the presentation. So these are AHI, which would be apnea hypopnea index. We'll look at this in more detail. Respiratory distress index is a variation of this. Oxygen saturation, which calculates the oxygen carrying capacity of the blood, and electrical stimulation as well, which can point to more centrally driven sleep or respiratory issues. So this allows for differential diagnosis and disambiguation. And this is a very important point when we navigate our way through the sleep environment. So apnea, to describe apnea really as a cessation of breathing greater than 10 seconds due to the collapse of the airway. Double collapse there. But these types, there are 3 types really: obstructive sleep apnea. This can be mild, moderate, or severe. We look at that. Central sleep apnea, which is a central nervous system driven phenomenon, and mixed sleep apnea, which are combinations of both. And this is its significance in terms of the interventions that may be deployed to deal with these issues. Hypopnea really is reduction to pressure of airflow between 30 to 50% for 10 seconds. This relates to the narrowing of the airway where there isn't a complete collapse of the airway. So these are collated into an AHI. An AHI is an apnea-hypopnea index. This ranges up to 5 events per hour is normal. 5 to 15 is considered moderate apnea. 15 to 30 is considered, 5 to 15 is considered mild. 15 to 30 is moderate, and greater than 30 events per hour is considered severe. And RDI, the respiratory tracks in the same type of metric. Oxygen saturation, as we know from our Apple Watches and from data on COVID, less than 95%, sometimes gives rise to significant respiratory considerations. So what's the spectrum and severity of obstructive upper airway breathing disorders? Well, they range from snoring to sleep apnea. Everyone that has sleep apnea snores, but not everyone that snores has sleep apnea. So treating snoring may be masking apnea. That's one consideration. But treating snoring may be keeping relationships together and dealing with other issues that are symptoms of an apnea presentation or not an apnea presentation. So depending on snoring begins with continuous irritation of the tongue and soft palate, creating acoustic effects, and sometimes that leads to upper airway resistance syndrome, which is a step up. Upper airway resistance syndrome can sometimes translate into mild sleep apnea. And there go, we have then the progression, not always to severe sleep apnea by any means. So simultaneously occurring in areas that we would be familiar with would be bruxism, gastric esophageal reflux and its effects, and perhaps not so familiar with restless leg syndrome, which is a hypoxic, which is a side effect of hypoxia as well. So characterizing the area of interest for us as dentists, really, in terms of when we navigate our way into this sleep medicine space, we're really focusing on this velopharyngeal area, and that's the area of interest. That's the area of effect and the phenomenon of dental appliances that have an effect on this particular area. It forms the basis of the types of interventions we provide. So these are just MRI images which showing the hypopharynx, oropharynx, velopharynx, and as if you cast your eyes across, you can see MAS is another name for MAD, or mandibular advancement devices, but these are reconstructed CT, cone beam CT images of constricted and opened airways, resulting from wearing mandibular advancement appliances, no appliance, and appliance. So as we understand the mechanisms of these particular presentations, well, what are the long-term downstream effects? Well, medically, they're significant, giving rise to hypertension, cardiovascular disease, secondary to hypoxia, arrhythmias, and giving rise to atrial fibrillation complications in the electrical mechanism of the heart. Immune system compromise, irritability, mood disorders, depression, things that are consistent with poor sleep quality, learning and memory problems, cognitive issues. There's a pronounced association with metabolic disorders, type 2 diabetes. Glycemic health is affected by hypoxic conditions whereby sugars are processed differently. So it becomes much more difficult to lose weight and much easier and much harder to maintain a particular weight. And we can see the effects of weight on these presentations later on. So sleep bruxism, we're familiar with dental damage, dysfunction, morning headaches, and this is a whole other area that we're quite cognizant of. And we can understand the effects of gastroesophageal reflux as it affects the hard tissues of the mouth, and soft tissue irritations are also a feature of this when it comes to airway obstructions. So what's oral appliance therapy for snoring, and what are mandibular advancement devices? Well, there are as many devices. There are days in the month, maybe days in the year soon, but there are these are variations of titratable or adjustable devices. This is a middle device. This is a classically fabricated device, pull-down device with a mechanical component for titrating the device. And this is a printed device. These are custom devices with tongue retaining for edentulous cases. These are classical monobloc devices that evolved over time, but various designs that were really just in-house designs that serve a function as well. So how do these devices work? Well, they advance the mandible, displace the suprahyoid and genioglossus muscles anteriorly. So they enlarge the airway. And it's that calculus of muscle activity that these devices induce, really at different levels, primarily at the velopharyngeal level, by altering the position of the mandible and the hyoid bone, that creates the phenomenon of patency of the airway, which is the modus operandi of these devices. So is there a difference between the classes of fixed, which we call monobloc devices, or one-piece devices, and adjustable devices, which are titratable devices? Well, there isn't really, but that would depend on the skill of the clinician and the accuracy of the position that's chosen as the treatment position. Obviously, titratable devices afford the ability to move a device forward and backwards and alter the protrusive range, and sometimes the vertical component of the device also. But any device is dependent on sufficient protrusion. So ergo, according to the literature, really, there's no difference when you reach the Goldilocks position or when the optimal position is achieved. But obviously, it's a lot more difficult to optimize these devices. If they're monoblocks, they require a lot more laboratory time or chairside time to adjust them, etc. And there are also seating issues with them, which are slightly more complicated. So moving on to how we collaborate with our medical colleagues in the provision of services. Well, sleep physicians, the guidelines really laid down by the American Academy of Dental Sleep Medicine, similar to the European Academy of Dental Sleep Medicine, and guidelines that are developed in collaboration with our medical colleagues as well at a local level here, would clearly outline the algorithm. So the algorithm is that the physician will make a diagnosis, is responsible for making a diagnosis, and will prescribe an oral appliance as a primary treatment or as an alternative treatment. So the qualified dentist or the dentist who has an understanding of the field will be given that prescription and and provide an oral device for that particular patient within certain guidelines. So many cases, physicians will not recommend oral appliances as a first line of treatment, depending on the severity of the presentation. And so a treatment which is continuous positive airway pressure, which we'll look at further on, is the standard of care for more severe apnea presentations. But they would be quite commonly prescribed by physicians for things like heroic or primary snoring. So qualified dentists then should provide oversight because these devices, as we know, any device that we place in the mouth can have side effects, and those side effects need to be monitored. There may be TMJ, occlusal, neuromuscular effects, so these need to be modified. Also, the integrity of the device needs to be carefully managed, especially if there are metallic or movable components in it that need to be evaluated in terms of their mechanical stability. It's the obligation of the sleep physician to carry out the follow-up sleep testing. That does not mean that dentists can't evaluate the accuracy of the titration or settings of their devices with sensors and other technology to better inform the physician of the optimization or other of the device setting. So it's a collaborative intervention, and communication is essential to optimize the outcomes for patients and to manage some of the occasional complications that may occur or the less than optimal outcomes. So these documents are freely available. This is a document that's available on the website of the Irish Sleep Society. So we're referring to OAT, or oral appliance therapy. What are oral appliance therapy efficacy limitations? Well, if you have a hammer, everything may appear to be a nail, but there are limitations to what these devices can do. As we know, there are limitations to the amount of protrusion that we can provide. So if we have a healthy craniomandibular arrangement with no derangement in the joints, good range of movement, and other considerations, which I'll checklist later on, then we can optimize the protrusion between 50 and 70%, maybe 75%, and optimize the vertical opening between 2 and 6 millimeters. But I think the thinking is now that the vertical opening should be as little as possible. And obviously the dentate status, if we have I'm not speaking about the dental comorbidities like caries or periodontal disease or other anomalies. I'm talking about just the static dental arrangement in terms of partial edentulous or also the distribution of suitable abutments to retain a device or otherwise. So to get the optimum from a device needs a certain amount of empirical setting of the device and an amount of adjustment, and that's reading the patient response and using technology to do that in a more efficient way. This is an example of a titratable device that's used in sleep laboratories, but it hasn't really translated into the clinical environment for dentistry, and we'll see why later on. But there are other technological aids that can be used. So positional aids, we know that the airway is more patent and the caliber is maintained better when people sleep on their side. So there are sleep trainers. This is an example of a device, Somber Pump, that by reducing the incidence of supine sleeping or sleeping on your back, the airway patency can be maintained. So that will help the efficiency of the device. Obviously, what isn't a light switch? This is a light switch. This is a light switch. We can turn them on, turn them off. Can't be a light switch arrangement, but because of the significant considerations around weight gain and upper airway patency, which we look at a little bit more detail, weight management is an essential component of this. So surgical requirements, well, where there are anomalous surgical presentations that are not associated with obesity, just a naturally occurring tissue bulk, or whether there are significant jaw relationship issues whereby there is a very crowded upper airway as a result of micrognethia. These are considerations for either soft tissue surgery or maxillofacial orthodontic surgery. So obviously, we're not presented with optimal patients all the time. So really, we have to look at, the amount of occlusal support we have, which is significant to some degree in terms of airway support as well, because collapsing airway is sometimes associated with collapsing vertical dimension. We have to look at, the feasibility of making a device for someone and looking at the various edentulous or partially edentulous comorbidities. So this requires for a little bit of inventiveness occasionally. This is going back some time now where we're using, say, monoblocks, which are just single piece devices, which can be extremely effective, as we know from the literature and clinical experience. These are modified devices that for compromised partially edentulous individuals that have significant apnea issues and also CPAP intolerance. And these are for edentulous patients. This is an example of a stabilized tongue retaining device where the individual is completely edentulous. So how effective is this type of therapy? Well, it's generally effective for snoring and obstructive sleep apnea at varying degrees. And the expertise is to test, really to test with protrusive grading the degree to which these devices can be optimized and the extent of the protrusive range, the ability to tolerate devices. There are a number of factors that inform how much protrusion can be achieved and whether it's wise to do that. Obviously, devices that are that sleep apnea presentations that are associated also with sleep bruxism, and we look at maybe a more subtle relationship to this, must be robust and must be of a certain caliber to resist the bruxing tendencies. And there are certain design features that inform more optimization of that. Is there evidence-based effectiveness of these devices? Yes, there is. Kate Sutherland's review showed that in terms of cardiovascular and blood pressure significant equivalence in performance of sleep appliances and CPAP. So an example of a CPAP device, which can be obviously quite obtrusive. But if you have a medically compromised situation and you have a 100% guaranteed outcome wearing a CPAP machine, and you can tolerate this device, then that is a very suitable solution for you. This might be as we say to patients, an oral device might be an adjunct or an alternative, depending on the severity of your presentation and the other steps that go into the management of your presentation, which may be considerable weight reduction or other maybe surgical weight reduction. Could be other considerations that inform the prescription or of the intervention. So significant effects on daytime sleepiness, and this is what we're looking for: subjective outcomes. Comparative crossover studies give rise to what we call emergent mean disease alleviation effects. So that means that if someone can only tolerate CPAP for 3 or 4 hours a day, but it's 100% effective, or it's a night, but it's 100% effective, and they can only wear it for 3 or 4 nights and then they can't tolerate it, there's a certain cumulative effect of that. But if someone can wear an appliance for 7 nights a week and it's not bothering them, but it's not quite as effective, then the cumulative effect at a physiological level can be equivalent. So adherence is a big issue. So efficacy is one thing. In other words, is it an effective therapy? Will it do what it's supposed to do? Yes. Predicated by, can you tolerate it? If you can tolerate it and it can do what it says, then it's going to be effective. If you can't tolerate it, it's not going to be effective. And that applies to oral appliances also. So we look at the mean disease alleviation compared to the alternative approaches. So one big problem really with obviously CPAP is, the CPAP tolerance. So the efficacy is offset by the greater tolerance of oral appliances or appliance therapy, especially in the mild disease. So obviously it's more portable, it's less obtrusive, it's quieter, it drives patients, and it can be very cumbersome to be bringing CPAP machines abroad on holiday, or obviously the cohort where many of these presentations arise are maybe slightly older, and maybe it's more leisure time, they like to travel. So an oral appliance can have a significant number of advantages for these particular individuals. Again, going back to, if we have a hammer, everything's a nail. We fall into this impaired anatomy region. So if we take CPAP as the door into the problem, CPAP will address all the various arms of the problem. All right. So if someone is intolerant to CPAP, we need to look at alternatives. An alternative could be an oral appliance that's augmented in its function by upper airway surgery, weight loss, or position therapy. But sleep and obstructive sleep apnea is not a uniform presentation. There may be aspects of this presentation that, although there is impaired anatomy, there's also ineffective upper airway muscles during sleep. There could be some neurological considerations. They could have a low sleep arousal threshold, which leads them to be more hypervigilant, and if that's the case, in terms of physiologically hypervigilant. So they respond to stimuli in an exaggerated fashion. And then there may be some ventilatory controlled instability, which means that there's a high effort for the same amount of oxygen intake. So there may be a combination of these factors that present. So oral appliances can sit comfortably in the middle of these therapies, but an overall view of the efficacy and effectiveness of oral appliance therapy must be predicated by an understanding of the field, and this is a physician-driven analysis, and our deployment of our appliances are to assist in the overall optimal outcome for these patients. So I'll mention this slide because obviously it's a whole lecture in itself, and it's not an area I'm particularly familiar with. This ventures into the maxillofacial and orthodontic disciplines, but a lot of the data on a lot of the in fact the eureka moment in terms of mandibular advanced appliances was mainly discovered in Vancouver on research to Pierre-Robin syndrome and the micrognathia and obstructed airways that these patients experience. And obviously there are degrees and there's a spectrum of craniofacial and orthodontic considerations that lead to smaller upper airways, smaller jaw sizes, crowded intraoral tissue, crowded tongue, longer palates. There's a whole range of things, but these can be developmentally handled as well to optimize and prevent some of the downstream effects of these presentations in younger cohorts. So to mention something about sleep bruxism, well, the actual repetitive jaw muscle activity, which is characterized, as we know, by clenching and grinding, and is right in our front door every day of the week. We know the prevalence. We know what we probably don't know is the diagnosis is optimal through polysomnography. So in other words, that the parameters that are measured in polysomnography PSG studies basically will elicit and demonstrate bruxing activity. So it's the absence of the nociceptive and proprioceptive response in sleep bruxism that caused the damage, obviously, and it increased in the magnitude and duration of clenching muscle activity significantly. So we know all the sequelae of this. What is not so clear is how is this related to sleep disordered breathing? So current thinking says, well, obviously the three theories, there's no relationship at all. It's an independent phenomenon. Secondly, it's a protective phenomenon because the thrusting will bring the mandible forward and then thereby opening the airway. Or it's an inducing, it's also causing some sleep apnea. So the jury is out on this, but one of the considerations here and the take-home message is that 30% of sleep bruxing patients also report OSA symptoms, or obstructive sleep apnea symptoms. So if that premise is correct, occlusal devices, standard occlusal devices, which will allow the mandible to retrude, can exacerbate potentially OSA. So treating bruxing patients per se may be managing and protecting vulnerable dental tissues, but exacerbating an existing propensity for sleep disordered breathing or sleep apnea. So this is something that's an ongoing debate. Now, the significance of dental sequelae from GORD are really, permanent lysis, just significant reflux. So if we can imagine what that's doing to the hard tissues, really the area of interest in terms of sleep disordered breathing would be also the effects it has on the texture of soft tissues, and obviously the chemical and the chemical washing of the surfaces of tissues, making them perhaps stickier or more likely to cause an occlusion in the airway, or stimulating vocal cords and neurological symptoms, and also concurrent with sleep arousals as well. So it can be a sleep fractionating phenomenon. It can be an anatomical or neurological anatomical surface anatomical phenomenon, or it can be a neurological phenomenon. So we need to be holistic in our overview of these presentations as well, and not just see one thing. So what are the patient selection considerations from a dental perspective? Well, obstructive sleep apnea, we're familiar with this craniofacial structure. We look at the soft tissue structures. We don't look at this so much the regional distribution of fat. Neural control of the airway is really not our department. But going forward, to investigate these presentations, well, we use specific soft tissue classifications that help us identify who are likely to be the individuals who will present with these particular problems who are the individuals that we can possibly help, and who's those that we possibly will not be of assistance to. Well, when we can look at the Malapati grading system, where if we get someone to open their mouth and look at, and we can see the posterior wall of the pharynx, that's fine. If it's less occluded, if it's more occluded, that's not so optimal. If it's more open, so this then is described by the physicians as a crowded upper airway. So obviously this is the vertical component of it with the uvula on that, and then we can have lateral pharyngeal walls. So they can also contribute to this collage of tissue or the drapery at the back of the mouth, as I like to describe it to patients. So this is an example of a Malampati 1, and pharyngeal walls are laterally displaced, and these are centrally displaced, long uvula. So we have a crowded upper airway here. So is this individual going to be making noise? Yes. Is this individual going to be making noise? Possibly, but not to the same extent. And is this individual more likely to have an upper airway obstruction? Much more likely. The craniofacial profile. Just to mention this, obviously, class 3 patients will have less protrusive capacity. Class 1 patients, less protrusive capacity than class 2 patients generally. High vertical Frankfurt mandibular plane angles, vertical translation of the mandible can lead to more problematic device constructions and also have propensity for longer term side effects in terms of prognatic effects that are not resolved and can have more significant temporomandibular joint complications. So high V-shaped, wide open V-shaped craniofacial profile presentations, as opposed to deep bite presentations, are different. So doubling down on an anatomical imbalance and blending in a little bit of obesity into this. This is an excellent slide, really. It really shows you the relationship between normal soft tissue dimensions and volumes and normal bony enclosure, the skeletal and the soft tissue. And this is the mix that will cause the airway patency to be normal or to be constricted. So if we add in excess body fats, and where this fat is resident more so, we'll have a look at in a second through MRI. And that will show us that, if we have increased tissue bulk as a result of fatty deposits, then that constricts this area. So this is a possibly correctable entity in some cases, because it's not anatomical, it's acquired. It's an acquired adipose deposition. But then we have the craniofacial anomalies, whereby we have small maxilla and mandible, tongue size disparity, and then we can have these constricted caliber of the airways. And this can lead to these cases of greater propensity for airway obstruction and noise and collapse of the airway. So when we translate this type of anatomical presentation, and we see really that this perhaps should be in a vertical dimension, but in a vertical orientation, as I say, but this is the model, this is the physics of really airway collapse. So the nose is a bony cavity, assuming that we have no nasal obstructions or excessive turbinate size and that. Then we have the trachea, which is a tube, like a tubing. And then we have this floppy bit in the middle, which is the pharyngeal wall. So that's subject to kinking and turning. So if the diameter is decreased, the airway, there's an increased velocity of air. Once the velocity increases, the pressure drops. It's like water coming out of a tap, and it's the same thing. So the propensity to collapse is greater when we have this constriction here. The wider the aperture in the pharyngeal space, in the velopharyngeal space especially, the greater the flow of air and the pressures are maintained. So a roundup of some clinical parameters, not everything, it's not completely comprehensive, but the craniofacial phenotype, and as I say, that's the hard and soft tissue descriptors that we've used. Status of the dentition, partially edentulous, so obviously clinical parameters, and if there are dental comorbidities, they need to be eliminated optimally before any appliance therapy. The occlusal relationship, are there anomalies there that would lead to design problems? Are there anomalies there that relate to acquired bruxing activities? Temporomandibular joint status, is there any sign of derangement in the joint, discomfort? The jaw relationship itself and the vertical dimension, because they affect protrusive range. The range of mandibular movement, that would be vertical mandibular movement and lateral movements, obviously affected by anatomical considerations and pathological considerations. Evidence of tooth surface loss, how's that been? Is that mechanical? Is it chemical? Is it a combination of both? And the soft tissue classification of volumes, and really, and then looking at the neurological status of you know, the age-related or ability to maneuver the jaw. So lots of those parameters are wrapped up in the Possal's envelope, just as a reference. So, are there occlusal and temporomandibular joint effects from long-term appliance wear? Yeah, there are. Yeah, there are predictors. But having said that, there are long-term TMJ and occlusal effects of no appliance wear also. So, and I mean that dentally, not in a sleep disorder breathing consideration, because there are growth changes throughout life, and there is drifting. We're now seeing phenomenon of contact point loss on implant restorations, which are ankylosed, and so there's a whole range of different. There's a whole range of different considerations there, but let me just go back there to. So really, yes. And where do they present? Well, they present with overjet, overbite, proclination of anterior teeth, and retroclining of lower teeth, or proclining of mandibular or maxillary teeth, and sometimes retroclining of the mandibular teeth. Now, having said that, the neuromaterials and the manufacturing standards that are now being provided for more sophisticated appliance design, etc., deal with some of these issues. And the manufacturing protocols, the CAD/CAM protocols, primarily milling as opposed to printing. Printing wouldn't be as accurate really in terms of the integrity of the fits, but it is sufficient. But if it's a necessary component to have absolutely no occlusal changes, then, you know, it's a consideration. But it's a balance between, you know, it's a weighted compromise, to say, between, treatment in the 50% protrusion position. The more you protrude, the more likely you are to have effects. And there is a defined preference for small vertical opening, leading to less occlusal changes. More protrusion results in more side effects. That's a given. TMJ difficulties, if the joint is presenting with anomalies or derangements to begin with, caution is required in terms of deploying this type of therapy. But this therapy can be beneficial to joint stability also if it is collated with a considered approach to the delivery of the device and a very measured titration. So that requires a lot of forward thinking, design thinking, and evaluation of the performance of the device. I mean, if the joint apparatus is not self-seating afterwards, after removing this appliance, there are techniques to minimize that. So we can minimize complications really with proper appliance selection. That means, material selection, fabrication type, and design. The appliance titrations, by that we mean the advancement as an incremental advancement, or an incremental advancement, or a managed advancement would be the best way to say that. So we want to avoid maladaptive protrusion, and we want to avoid, occlusal issues. Any change. Now, we use what has become very important in delivery devices is the use of morning positions. So morning positions can be simple devices. They can be like bite registration type devices. What the object of these exercises is like sitting in a long flight. You get up, you bend your knees, you walk around. You may be sitting in the same position for a few hours. We're holding the mandible in a position that it can achieve normally within its range of movement to speak and to chew, to incise, but we're not holding it. They're only for milliseconds during the day. The mandible isn't held in that position. So the calculus of the muscles needs to adapt to that position, and sometimes it can be a little bit reticent when it comes to adapting back to the occlusal or centric or maximum cross-pacing position. So what we do in those cases is to manipulate the jaw with a little spin-like device, bringing the jaw forward and back, and then initiating a clenching activity, which allows compression of the jaw joint. And depending on the response, this can be done this should be done on a daily basis, or it can be done several times during the day in the initiation of the device wear. Good clinical record keeping is essential in this discipline. We want to have an informed patient body to understand the benefits, the risks, the alternatives of these devices. We want to understand what we want to enter into the management of their conditions in a relatively predictable fashion. That requires education as regards the presentation, as regards the limitations, as regards the potential side effects. But the benefits may outweigh the risks for these individuals, and that needs to be clearly communicated. But we're not communicating always with patients. We're sometimes communicating with lawyers, or we're communicating with other people, and so we need to have accurate records. And these are just examples of the clinical records of the devices in place, and obviously recordings of the titration sequence and responses. So, overfitting. Apologies if I'm. I think I may be blocking out some text here, but overfitting. So, how to predict non-responders? Well, that's what we'd like to do before we start, isn't it? And so, again, it's back to the overfitting is the hammer nail thing. But we're really looking to deploy devices that have predictable outcomes, and the outcomes aren't always predictable. But as you mature, perhaps the benefit of experience is that, as they say in the stock market, there's some trade, the best trades you make are the ones that you never do. So in some cases, it's not appropriate for all individuals, this type of therapy. And there is an objective screening activity, but there is also a subjective kind of feeling in terms of likely tolerance. So sometimes it's necessary to use maybe provisional devices, or to dip the toe in the water really with these devices to see if they have some form of effect for these individuals or these particular patients. But again, I'd say if we have an holistic view of what we're offering, what the alternatives are, if the alternatives are if CPAP is the alternative and it's not tolerated, we can do our best, but this is a collage of medical issues that need to be addressed by the physician as well. So we can do our part and contribute, but we may not be able to completely ablate or completely solve the problem all the time. But we have a relatively predictable outcome. So in terms of technology perspectives, well, just look at a couple of these things. Just thank you for your attention so far, but I just wanted to finish off really with this section to look at some interesting things that are occurring. So we have this mandibular advancement devices, MAS stands the same thing. And then we want the titration that occurs during PSG. Ideally, if that was occurring in sleep labs, that would be great. So we would have hard-led data as regards what would we want to do with a baseline data to work with. So some home sleep testing and titration testing as well, testing for the efficacy of our devices with sensors. That's really important. Adherence sensor technology are the patients. One of the issues with oral appliances for physicians are that while they can generally measure, not always, the compliance with CPAP therapy, they can't measure the compliance with sensor therapy, and that's a subjective, or with oral appliance therapy, that's a subjective reporting. Whereas a CPAP can upload cloud-based data, so they can see, red, yellow, orange in terms of whether this therapy is being consistently used by the patient. Cone beam CT under medical prescription can be extremely useful in terms of outlining the structural anomalies that may lead to the necessity for a more aggressive intervention. But interventions of a surgical nature may be supplemented by oral appliances as well, even of soft tissue. So BMI facial calculation, as we said, there are significant considerations in the amount of adipose tissue, which normally is deposited at the back of the tongue, and this can be correlated, and the BMI can be correlated to the like a phonology of the face. So it's an interesting technology. And then, of course, the big one, the digitization of clinical procedures. So this is the MATRX study of the polysomnograph. So patients in the sleep lab, the technician is recording. This is the MAD device. This is the mandibular advancement device has been titrated, and in various increments to the optimal increments, so that the optimal airway titration is established, locked, and the appliance is made to that. So that's the bite registration under sleep laboratory considerations. So then there's a whole range of different home sleep testing kits that give valuable information in terms of the quality of sleep, the fractionated nature of the sleep. It can give rise to, you can look at specific parameters. If we know that we have obstructive sleep apnea, what we're following a diagnosis from a titration perspective, what we want to know is, we want to know the heart rate, we want to know the oxygen saturation, we want to know if there have been any hypoxic or apneic events, and score those, and we want to know, wrap that all up in the total sleep time, and that will give us an idea of the efficacy, the effectiveness of our device and its efficacy. So sensor technology can be embedded in the devices to track consistency, where this is deployed in a sleep device, but it's generally been deployed into recalcitrant orthodontic patients who are maybe not wearing their functional appliances, so that the orthodontist can, that's where the technology emerged. It has certain benefits, but I think it's going to be superseded quite soon with more sophisticated technology. Cone beam CT, again, I referred to that in terms of anatomical anomalies, predictive enlargement of the airway, fabulous imaging potentials, and also difficult can be used perhaps maybe to view the effectiveness of the oral appliance therapy in medical critical situations. But then again, that's a physician prescription, but it is a technology that's available. This is what I mentioned, BMI predictive. This was 14,000 subjects in database, and there was a predictive algorithm for calculating the BMI relative to the facial phonology, to facial analysis. So, clinical data acquisition and management. Well, once we have anatomically and clinically evaluated the patient and begin the process, obviously we need to record a position. So we use, there are different gauges we use to optimize the protrusive, to establish the protrusive range, and then optimize our choice of that range relative to the effects that we might have when the patient's in the chair. We can test for snoring capacity and things like that. Ideally, intraoral scanning. To this, we call this a construction bite. This would be the bite registration, the construction bite registration. Intraoral scanning, optimal. Creates a whole flood of different options in terms of design. The trueness and predictability of these are truly amazing, and we can modify, we can design. So once the file is exported, it can be analyzed. It's an ideal communication platform for putting in design features, removing other features, making sure that we're optimizing, the effects we want to create without creating the negative side effects. So that is a tremendous bonus. So at the end of the day, from a practice perspective, from an optimization of the process in terms of not wasting time, patients' time or resources, and not wasting our time and resources, there's the trueness and precision of the actual data recording, the material science that flows into that, and the digitization of the whole process to provide clinical chairside fit times which are good. Patient comfort and acceptance, making sure it's easy to insert and remove, doesn't cause any type of anxiety in the patient or potential damage to fixed restorations or other types of prosthetic entities. We want something that's robust and durable, and this is where the material specifications are really coming along. So we have much thinner appliances that are much stronger because of the compressed nature of the pucks that they're milled from. We want demonstrated efficacy. That's where we bring in our technology and use our sensors to establish that we are delivering for the physician what the prescription is. In other words, that we can return the patient to the physician saying this is the optimal titration relative to what we have to work with. And then obviously we also can use digital platforms or digital STL files to monitor occlusal stability, so we can actually track if there are significant occlusal changes occurring over time. So from the fabrication, from the STL files, which are created from the scans, formats, well, direct CAD/CAM printing. Printing is very good in certain situations. Milling is more accurate, no doubt about it. Materials developments are constantly improving. The chemists lag behind really, I think, on the printing. The printing is a different process, and just because maybe it has been excuse me, just because it's been deployed at a kind of workstation level now, it doesn't necessarily mean it's the optimal thing for making these devices. And sometimes the printed devices are more difficult to adjust. I say the fit can lead to more drifting within the device, micro drifting. But obviously, in the digital area, reproducibility is such an easy thing to do. So we have, I would say, lots of options in these devices, getting more sophisticated all the time. We're basically converging to a very predictable offering for many patients. So hopefully I've answered some of these questions today. And really, as I said, what we have to do with sleep medicine. Maybe you have a better idea of what sleep disordered breathing is, you know, how significant it is in all our lives, and how important non-disrupted sleep is to everyone and their quality of life. How we collaborate in the management of these presentations with our medical colleagues, and what the sequence of communication should be, and how to properly manage patients. Understanding what oral appliance therapy is, it's somewhat its limitations as well. Managing or ideally preventing side effects, and just looking a little deeper about the considerations about patient selection, not overfitting the solution, getting away from the hammer and the nail, which is always a problem somewhat in dentistry. But you know, we've wonderful therapies, but you know, need to be employed appropriately. And the newer technologies, I think, that will impact this area, and in fact all our practice, like from any prosthetic component now that you're making to these newer mind databases, produce huge amounts of information that can be deployed to optimize and really allow greater convergence in terms of the offerings that are out there. So hopefully you've enjoyed the presentation. If there are questions you have, you can address them for my attention. And again, thanks to Elaine, and thank you to Aoife for adjusting the presentation for us. And I wish you a good evening, and thank you for your attention.